Hello and welcome to our virtual rhinoplasty meetings. My name is Dr. Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 6, we've moved over to Beverly Hills, California to visit Paul Nassif from Botched. Paul's speaking to us about Diced Cartilage Glue Grafts. So the questions are going to start rolling in now. But Paul, we spoke very briefly about our now with the COVID and what we're going to do around surgeries. And I know you were telling me that you've been very involved with this rhinoplasty think tank. Please share a little bit around that first before we carry on with questions.
Sure. So I've been actively involved in dealing with helping some hospitals get masks and N95s, and we're trying to figure out now how to get back to surgery when things are opened up. And the issue now is, about the blood testing. Your IgM is actually not going to get positive. So if you have the infection and you're fresh within 3 or 4 days, you might not come up, and that blood work is not going to show it because we have an IgM and IgG it's showing. So what we're doing right now is we are, when this all starts, we can go back. We're going to have them come to our doctor in LA because a lot of patients are traveling. Kind of have them get here about 4 or 5 days before, go to the doctor immediately, get two nasal swabs 24 hours apart, and there's the sensitivity is only 70%, so we're going to do 2 in a row. That's going to show if there's something immediate. The same day we're going to get blood work, and that will show, one, if you're immune, if you already had it and you have IgG, or if you have, during day 5 or 6, your IgM will rise. And we're going to do that. Then we'll make sure that they are quarantined, pretty much do the best we can to, tell them the importance of it. Of course, we're going to quiz them about temperature and everything else and symptoms before they come out. And then, of course, whatever PPE we're going to use, we're still working on that. So that's what we're going to do when we start opening up to do surgery again, because I was, again, talking to Dean about this. He's still doing a few cases that, infections and things like that. So what, when you're inside the nose, obviously that's your highest count. But again, besides, using a suction, we're not doing any sinus work. So with rhinoplasty, it's still, I think, high risk. But that's why we're going to be very careful and see what we're going to do. So that's my, as you and I spoke beforehand, that's my 2-second synopsis.
Awesome. Thank you. Okay. So, Paul, I'm going to start going through the questions as they roll in. Anyone's welcome to type a question about anything they want to ask around the lecture. And also, obviously, if you want to ask about Botched and social media, etc. So let me roll in with questions here. Okay. The first question I've got here is, when do you typically begin 5-FU injections post-operatively? And how many treatments do patients typically need?
Well, I use 5-FU for actually any swelling. If I'm taking away a lot of super tip, polybeak scar, for example, I'll inject it at the end of surgery. I'll go straight through and I'll use 0.15 or 0.2 cc's. By the way, I'm seeing you. Hold on, let me get my photo here. There we go. I can see myself now. Hi, Dr. Peng. I can see her there. In the screen, and I'll start immediately in surgery. So that's what we'll do, and then I'll usually start injecting them weekly, sometimes every 2 weeks, and I'll usually will go, it's 1 to 10, so let's say I put in the syringe 0.2 cc's of 5-FU, and then 0.02 cc's of like K5, which really doesn't do much, but we'll start that immediately. Sometimes 3 or 4 or 5 injections every 2 weeks usually is the way we'll go.
Awesome. Thank you. The next question is it possible to carve and shape the glued diced cartilage?
Oh yeah. You mean, well, obviously after it sits for about 3 or 4 minutes, you could actually carve it easily. I mean, we'll make it thinner, or if I put it in, it's a little bit too thick, we'll shave it down. Or I'll cut into sections and I'll mold it and compress it for infratip, lateral nasal wall. Now here's a really important point. So lateral nasal wall irregularities or depressions. So what I will use is sometimes the thinnest shaving of rib cartilage because it's really thin. And however, now with this, I use this. And even with thin skin, it's been able to mold it. In addition, this is another interesting, I had a patient before we stopped, she had a huge hump reduction. And you know, as you shave off that cap of the bone, your middle vault becomes longer and your upper lateral cartilages, and you get the long middle vault. And no matter what, putting these extended spreader grafts all the way up there, I still had an irregularity and a depression in the left perimedian rhinion. It was like a big gap. So I had to put cartilage in there. Obviously, if I put any type of covering, it's going to show a big bump. So what I did was I took the DCGG and of course I get the permission in advance because it is obviously from a blood bank. And I took a small piece, made a small piece of it, and I took my Freer and you mold it like a pate and you put it right in there. And it completely filled that hole. And it worked beautifully.
Awesome. Okay. Another question here is, how do you suture the glue graft to secure it in place?
You don't suture. You just put it in.
You just leave it.
Yeah. Remember, the DCF would do, but not this.
Another question. Do you find that when using the syringe, the dorsum is too round?
We haven't really seen that because I look at those again, those lights down the dorsum, and we'll shave it or narrow it and we'll play with it. And that's why using either the mold or just that 3cc syringe, I think obviously the more and more you do play with it, in the beginning it's going to be hard, and then you can take it out and shave it. But I haven't really experienced that myself. I'm happy with what I've been getting. And so far, I think we've done, I don't know, Dr. Smith or Dr. Pang or anyone you can answer this. What have we done in the last, 5 months? Maybe 50 or 60 of these already? Or pieces of it?
Yeah, I think you've been using them basically even for other small grafts. And just to address the other question, I think sometimes when you're using them for the tip, after he carves it down, he does suture it in place sometimes. And for a lot of our suturing, we use 5.0 PDS on a P3 needle.
Wait a minute, suture
but
what?
In general, no, like for certain areas for the tip and things like that.
No, but they're talking about suturing in the Diced Cartilage Glue Grafts.
Right, but on the dorsum, there's no suture.
Okay, cool. Thank you. I'm going to carry on going with some more questions. Sure, they're running on you. Did you observe any hypersensitivity reaction or prolonged erythema with the glue?
So far, 0. We haven't had
Awesome.
anything yet so far.
Okay, any thoughts with regards to fat and cartilage combined in the fascia? Pre-fat nano improved skin prior to dorsal augmentation.
Yeah, again, that's something that Dean was talking about. And so we started talking about, because I've been doing nanofat after I went to a lecture from Dr. Nabil Faki in Beirut. And he was showing me all these incredible results with nanofat. So then after Dean was talking about it, then we started doing sniff, sharp needle. We started going into the fascia with our DCFs, especially for horrible skin. Or even if someone has horrible skin now, we'll put the DCGG layer. And on top of that, we'll take the perichondrium from the rib, usually perichondrium, and Grace will give me a nice piece, or rectus fascia. I don't really like using temporalis fascia anymore. And then we'll inject it with nanofat or whatever it is for bad skin. Then we'll inject the skin itself.
Awesome.
And now in regards to volume, though, with fat, the most I've used, we'll use SNE, sharp needle, emulsified fat, but we do not count on any of the volume. We're just pretty much adding it to the perichondrium or the fascia, and then the nanofat to the skin.
Awesome. Okay, another question is, what is the advantage of using diced cartilage over carved rib cartilage?
Talent. I mean, I personally don't want to, again, a lot of everyone out there who's listening, I haven't seen their, the results from using the graft itself. Like, again, I'm talking about, because Dee and I have a lot of talks, so when we talk frequently, I don't know, he's supposed to be listening to this. Dean, are you there? I told you to make sure you listen to this talk, because he keeps wanting me to do his graft. Harry, did he even click it? If not, I'm going to, I'm not going to listen to his talk. I'm going to get pissed off at him.
I'm going to look for him, and if he's here,
Anyway, the bottom line is, I think it's really, you have to have incredible talent to put in that beautiful graft. Yeah. I like this right now. Here, I'm texting him, and of course, let's see here. He'll say he forgot, or he's
he's here. He's a panelist.
Oh, there he is. See if I mentioned. Oh, all right. Oh, by the way, since Dean's on, I got to do this plug. Everyone buy his book, and you're going to see this about 5 or 6 pages long, especially with that big composite graft, because I have basal cell here. And yes, Dr. Peng, I know you're looking at that scar. How great it is. Oh, there he is. So how'd you like that plug, Dean? Tell us, how'd you like it?
That's great. He's actually going to be our last speaker for this month. And then next month, we got a couple of other guys. So
yeah, he's talking right now. Talk. Hey, Dean, unmute your thing, though. You're on mute. Unmute your Zoom thing. There.
Can you hear me?
Yeah.
Yeah, you have a solid graft on your bridge, dude.
No, I don't. I do not have a solid graft on my dorsum. I have septal extension. You put a solid graft on my dorsum? Thanks for telling me. Anyway.
That's great. Okay, I've got a question from Steve Perlman for you here. He says, do you think there is any difference between dicing finely versus very small, thin wafers that Abel Jan Tasman suggests?
You can try that. I mean, Steve, why don't you try that when you go back? And I love to, because we actually do that. You could glue them together. I think we did do that once in a certain area. I'm sure it could work fine. But again, one of the original things, and again, this is another discussion we had 7 years ago, was about the size of that cartilage. It's got to be small and chopped. And the chondrocytes are still fine. So we haven't had any problems. So that could work.
Okay. Do you have any experience using diced cartilage graft without the fascia?
Well, that's what this was. There's no fascia here. Yeah. This is the diced cartilage glue graft is straight, tissue. And
okay. Another question here is, does the glue diced cartilage resist skin contraction better than DCF over the long term?
Again, our 6-month results, I haven't seen any skin contraction. I have not seen any irregularities, luckily, that I've had to go back and redo. Because again, when you have that big parachute of fascia, and then you're filling it with volume, and there's a lot of edema, even when we try to squeeze out the edema and the fluid, you still can get that skin contraction, which can push the cartilage, as we saw, either cephalad or caudal. But with this, you got one, and it's pretty firm and durable. When after this glue sets in, you let this stay for about 5 minutes, it's a firm piece of graft. It almost feels like a silicone graft. Obviously, it's not as firm as what Dean does, but so far I've seen no problems with it.
Awesome. Okay, I've got a question from Ali Reza all the way in Iran. He says, Dear Paul, for isolated radix augmentation, question number 1, which technique is better? Is there any need for fixation of DCF to the skin in the radix, or only put in a pocket? And then the second question was, what about free diced cartilage for radix augmentation?
Okay. So I went through a stage, and there is still, in the infra tip, I'll still use it when the nose is closed, except for a small little open incision. I still will use in that same Botox syringe that you saw with the plunger that goes all the way through. I still will use FDC in small areas, straight injected. I still will do that on patients that I'm not using. It's not predetermined that we're using fibrin glue. I will use it. And I will use it in a little depression. I will still use that sporadically. And I overcorrect it maybe about 4 or 5%. So that's number one. I use it sparingly. I used to use it a lot more. Now I use it less. But especially if you want to get some rounding, you want to get a little bit more volume, DCF, especially after you close up on your incisions, have a little opening in the facet, take that syringe, inject it in, and you're set there. It does work beautifully. Or as plumping grafts, wherever you want to use it, it can work very nicely. You can do a nice closed rhinoplasty, and you can put your radix graft in. Again, as long as your pocket is not, too big, you slide it all the way in there, your DCGG, and you make sure it's in place and then tape it well. You don't have to fixate anything. At least I have not seen any movement. And Grace, would you say we've done about 50 or 60 of these?
Yeah.
And what will happen, by the way, is you saw just one extra point. And what we do is we operate simultaneously. I'm opening up the nose and deconstructing completely, especially in these hard revisions where the skin's horrible. Grace now is, she'll remove the rib now in about 20 minutes on most of these patients. Remove it. You'll remove it.
Oh yeah.
And then after you do your Valsalva and put in 1 or 2 sutures, she'll, especially either she or one of the fellows will still go start carving immediately. So we save we save all that time. And I already tell her what I need. And then she'll bring me the grafts and I just keep going. And then she'll go and close up the rib, usually.
Yeah.
Cool. Okay, another question from Danny. He says, thank you for taking time. It's been an informative lecture. Do you ever find the graft has moved post-op? And if so, how long can you still mobilize the graft?
With this, I haven't had it happen yet. However, now after having to go back in the nose in 1 or 2 weeks after surgery, you want to really get it before it starts to settle in. I would move it then. I would make an incision if I had to, open up, free up the tissue and move it immediately. I would try just digitally to move it, but I haven't had to do that yet. As you saw with that one DCF patient, I went back in day 9 or 10.
Awesome. Okay, a question from Ziad. He says, what's the safest way to augment the dorsum, firstly? And secondly, any tips to minimize problems when starting out doing DCF?
All right, we're going back to DCFs. So I'm not doing that anymore. And so with DCF, I have to tell you, it's a huge learning curve. And you saw some of the videos. Matter of fact, like I said, the American Academy of Facial Plastics has that whole long video. So I'm going to say that because the results to me are varied and the problems, I've been doing it for like probably 13, 14 years, I stopped. So I'm going to say to any new people, don't do it. That's why I'm talking about the Diced Cartilage Glue Graft, because you dice it, add a little bit of glue. You don't want to overdo the glue, obviously. And then you make yourself a cute little graft like you just saw here. And I think, obviously, for anyone, all of us here are rhinoplasty surgeons, or if you're even residents or fellows that are listening to us, since I know that, Cameron, you were so gracious to get all the fellows, they all have the links. This is, to me, a safer way in regards now to dorsal augmentation. However, you're going to hear, we're going to ask at the end of this for a few minutes. I do want Dean, I told Dean I wanted him to give his 2-second synopsis. Obviously, if you're advanced, to me, it's very hard what he does because he takes his time, spends about 30 minutes, maybe less, carving out that dorsal graft. And, that's a hard thing to do. And I'm sure a lot of you European or Middle East docs, or if there's any Turkish docs, are great at that. But again, that is something that's very advanced. So you don't get any, again, that's when you're going to start having problems, again, if we're not doing it right, where you'll start getting the convexities and the issues with that. The warping. You got to make sure you do that right.
Perhaps it's an opportune time for Dean to share on that now, if he wants to.
So, Dean, I wanted you to listen to this and Tell us your thoughts.
Well, I see the utility of DCF and diced cartilage with the fibrin glue, but my thought is I'd rather take a solid piece of cartilage and use the right side of my brain and create a really nice looking graft. It doesn't have to be perfect because you've got skin over it, and put it on the bridge, and you are creating a very close one-to-one association between how your graft is carved and how your dorsum looks. I think rhinoplasty is an artistic operation. We're facial plastic and plastic surgeons. We went into the business because we want to use the right side of our brain. And carving a dorsum, to me, is one of the coolest things you can do. Because number one, it's a lot of fun. I love to carve, I love to whittle. And you put the graft in there, concave side facing down. You suture the perichondrium to the undersurface. You make a bunch of little perforations in the bone, and that allows that perichondrium that's sutured to the undersurface of the dorsal graft to rigidly fix to the bone. And literally at 6 weeks, you can't move the graft. So it feels very natural. So let's say worst scenario. You put the graft in, it's a solid piece, it bends a little bit. Paul's talking about revising the DCF. DCF to revise is really difficult. I have found that with the solid pieces of cartilage, if you have little small issues, a little curvature, I can actually take a 16 gauge needle, go through the skin, cross hatch a little bit on the concave side, and in a couple days, that graft, or almost immediately, that graft will start to curve back to the midline. The only curvature that's really, really key is the concave surface of that graft needs to be facing down. I know there's a lot of people out there that do use this technique, and particularly in Asian augmentation rhinoplasty, and I think it's very effective.
Wow, thank you very much. That's Paul. Does that answer your questions there?
Yeah, I already knew. Obviously, that's his thing. He loves whittling that, like he mentioned.
Yeah.
Again, you understand, you got to sit there and carve that perfectly. And again, not many doctors can do that. So for the fellows that are listening, obviously you want to work yourself up to that. Dean's got great videos and stuff to show how he does that. But especially in his beautiful books, different the chapters there, he's got plenty. And especially, I got to tell you one thing that's, that's, again, a hard thing when it comes to dorsal augmentation. But the utility of what I like of the DCGG for me is, like I said, I'm using it everywhere. So after I've, whether it's perimedian domes, anywhere, I like to use that. Mm-hmm. And that's where that softness, and you still can get the firmness after it heals. That's why I like using this, and that's why I gave this talk.
Awesome. I don't think we're going to get through all these questions. They're just rolling in. A question here from Ellie is, what about infection with a Diced Cartilage Glue Graft?
So far, since I told you, we've done 50 or 60 of them in the last, 6 months or so before we left the office. 0 so far. 0 revisions, 0 problems at this point. But again, give me some time to, let's. I need a good year before I come back and tell you my final thoughts on that.
Awesome. Okay, Tarish says, Dear Paul, number one, how much absorption of diced cartilage with fascia and with glue have you experienced? And secondly is, free diced cartilage used for radix augmentation, how do you keep it in place?
Okay, so we answered that a few minutes ago.
The second one.
Let me, I'll quickly go through that. So far with the DCGG, again, on the 50 I mentioned, no problems yet, okay? Besides the basic swelling and edema. And number 2, again, if you are using a DCGG, you make your pocket, slide in with your bayonet, make sure it's centered, go to the top, take your photos. Again, look at those highlights as you look down the dorsum. And again, just like you're not going to get that great of highlights with the DCF, with this, I find those lines, as you saw on the thing, to me, they were nice. And again, are they as good as the dorsal, unblocked piece of cartilage? Possibly not, but I think it's pretty close. That's my opinion.
Awesome. There's an very interesting question from Cyrus. Wants to know, firstly, What technique or blade do you use to finely dice the cartilage to achieve your preferred consistency?
Well, that's just a single edge razor blade. I mean, that's all that is.
Okay.
I mean, they're surgical. I mean, they come in and you sterilize them. And, you know, the biggest
They're from
thing,
Henry Schein.
Henry Schein, but these folks come out of the country. I mean, your medical distributor are going to do it. Yeah. So.
Okay. And then his follow-up question is, do you apply both the thick and thin components of the TSEAL? And are there nuances to this application you recommend for stable structure?
Now, you got to, you have to do a thin layer. We do what, about 3 layers? Probably of the TSEAL.
We do multiple layers. So depending on the height of the dorsum that you want to achieve, then you basically will do a little bit of TSEAL on the bottom, mix in a little bit of the diced cartilage. Once that sets a little bit, put in some more TSEAL and then put in some more diced cartilage, and then just keep going depending on the height of the dorsum you wish to augment.
Awesome. That's great. Okay, we're going back to the nanofat. Here's a question. Regarding the nanofat injection, can you elaborate on how much you inject and what size syringe, cannula, and syringes you are using?
Yes. I mean, if and we use the tulip system, and if you do it properly, and you could also mix some PRP in there if you want to, but if you do it properly, you have a 1 cc syringe, Luralock, and if you get incredible nanofat, you can inject through a 30 gauge. And you just inject it through the, I mean, we inject the face and the neck and the décolleté and everything. But you just, you know, inject it all through the nose into the dermis. Now, but I will tell you, sometimes we got to go down to a 27 gauge. But try to get up to the 30. And again, it's that whole emulsification of, you know, through the different small cannulas from the tulip system. And there's 3, and then a filter.
Awesome. Okay. This one might be difficult to answer because perhaps you haven't been doing it long enough. Dear Dr. Nassif, how long is the survival of the glue graft compared to the DCF, and how much does it absorb in time? Is there any tip for having more chondrocyte survival?
So I know that we're not, you know, we're not compressing, we're chopping. So I still think in those small pieces of cartilage, because we go back to the DCF, or I've went back when I've just used diced cartilage diced cartilage only, and I've had to go back for a revision or something, I see the cartilage. So far I'm going to say in the last 15 to 16 years, with diced cartilage, I haven't seen any problems with straight resorption. Now, however, again, with the DCFs, we've had the problems with movement, okay? Mm-hmm. And some of them, especially especially when using fascia, if you're using some of these other, you might even get increased chondrocytes. So we haven't had much problems where we've seen, again, except for the movement of the cartilage from the DCF, the contraction, I haven't seen a lot of it go away. And again, with this, we've only been in this for 6 months. 6 months so far, we haven't had any problems. You got to come back and look at a year and a half.
Okay, we're quite wide. We've got participants from around the world. So again, thank you to everyone who's participating. One of the questions has come up: in countries where there is no TSEAL to be used or available, do you have any tips of alternatives?
Well, I mean, you know, when you have a, platelet-rich plasma, the point is you also have PPP, the platelet-poor plasma, and the question is how much fibrin is in there. You know, so if you add maybe some thrombin and some calcium chloride, maybe you can get that up a little thick. I don't know, but I'm trying to think what else that you guys can use out there that just, that's going to sit there. I mean, even if you let blood sit there and maybe wait for 15, 20 minutes to see if that becomes more gelatinous, and starts to clot, if you can even use something like that. That could be another idea.
Thank you. Thomas Roma in New York's got a question for you. Do you have any objective testing for nasal tip skin viability?
I will tell you this is like a friggin' advertisement for you, Dean. I remember, about 7 years ago, I asked Dean that question. And of course, he'll jump in and tell you something different. Obviously, what I do and what he told me to do is inject some local with epinephrine in the skin and just see what happens to the color of the skin. I remember that from a long time ago. But for me, since I do these extremely destroyed skin of the noses, Obviously, I ask them, what's going on? Is your nose turning purple when it's cold? I try to get a good history. But, even in that situation when I have to operate on these patients, I just make sure they're doing hyperbaric oxygen before I prep them. And then I prep them with everything else. I do a whole ischemic nose protocol after. But prior, only that, and I would do that episodically. Dean, do you want to answer that one?
I think one of the best indicators is what happens to the skin when you're in 40-degree weather. And if the skin turns blue, I tell patients you're not ready. So, there's a lot of things you can do. Paul talked about it. What I'll do is I'll take the nano fat and I'll inject it. So you have to make sure you don't go intradermal, because you can knock the skin off right there. So you have to go deep. But what I've been doing for the past 6 or 7 years is I'll take either costal perichondrium or temporalis fascia, and I'll inject the nano fat into that tissue and as a substrate and lay it over the tip and underneath the compromised skin. And it's just unbelievable how it recovers the vascularity. And I agree with Paul that hyperbaric is real important. A good 7 or 8 dives post-op is very helpful.
Yeah. So that's it. And hey, by the way, my fellow who wrote that little paper that we already did for the DCGG said that the study with Tasman showed increased chondrocyte survival with fibrin glue. So the fibrin glue actually increased it.
Okay. Now there's a question both to both yourself and Dr. Tiromi, saying your post-operative antibiotic regime, both oral or topical, for your revision rhinoplasty patients.
Go ahead, Dean. You do that, because I'm still doing what you did to me a long time ago.
I'm a big fan of these irrigation catheters. I take it's basically a 22 gauge angiocath, and I put it in the marginal incision. I suture it to the lateral wall splints I use and irrigate with a Cipro solution, half a cc, very slowly every 3 hours. And knock on wood, I have not had a major infection in a good long time. And I think the reason is because you don't give the bacteria a chance to accumulate in the area. So if you're irrigating every 3 hours, then you're clearing any potential bacteria that can collect, particularly in these secondary cases. So, I also do antibiotic soaks with a 2x2 gauze. And I do that every 3 hours as well. So the combination of those two things has been huge on preventing infection in these complex cases.
Wow.
But you're still doing post-op antibiotics then. You're still doing what? 2 different ones? You're doing Cipro and...
Yeah, I do Cipro and a cephalosporin.
Yeah.
But there's a lot of patients who are allergic or can't have the Levaquin because of joint issues. And so, in some patients, we're going with just one antibiotic. But I am convinced the key is the irrigation catheter and the 2x2 gauze.
Yeah, we do that. So I do these Cipro gauze, which is either 500 milligrams in a half liter, keep it refrigerated, or a gram in a liter, right, Dean? And yeah. He made me do that with my nose, but we do it 5 days before. We culture everybody, by the way, first, especially if they're coming in a month before. And then we treat whatever they come in with. Usually a lot of it's MSSA. And so we'll just use some Bactroban. And then we'll treat them, and then we'll do the double antibiotics if we can after. I do not do the irrigation like you do, but I probably will start doing that in some of these high-risk cases. But we do the Cipro soaks, also that Dean was talking about with the 2x2s.
Awesome, thank you. Back on a question around the fibrin from Prof. Mardery in Durban, South Africa. He wants to know, he says fibrin glue adds volume, but usually resorbs after some time. Does this affect the results obtained?
Remember, again, these are thin layers of fibrin glue. I mean, just a gentle layer, so it's not adding volume. If you do a huge layer, you're right, it is, then you're going to lose a little bit of volume. It's almost like making a peanut butter and jelly sandwich. The 2 pieces of bread are the cartilage, and if you have a big layer of peanut butter and jelly, it's going to get wider. So we just want a very thin, and we let it sit there and rest for about a good, 10, 15 minutes, Grace?
Yeah, we'll let it sit there, and basically, since I'm going to be doing it right after harvesting the rib, it basically can sit through the majority part of the rhinoplasty before then he puts it in. So it's sitting there, then it can actually be easily carved because it's settled into a little rubbery implant.
So actually a couple hours.
Okay, so we've got another 7 minutes left at the most. So thank you for a great talk. What is your threshold for leech use from Roxana?
Let me just tell this person 7 more minutes. So we have a whole protocol for the ischemic nose, and obviously they have to stop smoking at least 6 weeks before. But I think now we're finding even past smokers, there's more of an increased risk for ischemic changes. Obviously, anything we're rotating or lengthening the nose puts them at increased risk more than anything. So if that nose, when I look at that nose and I start seeing that purple discoloration, or if it's someone who's got extremely thick skin and is bleeding, and you know that when you close that nose, that they're going to accumulate blood inside that tip, I will use a leech. Mm. And so if I see that color change, I immediately get those leeches in there while they're in the recovery room or later on that evening or sometimes the next day. And luckily we call her the leech lady. And so she brings, again, it's not Leech USA or whatever, wherever everyone else gets their leeches. But we do it quite a bit, and they're all on Cipro usually. And remember, it's Hiridan, the anticoagulant. And again, it keeps that blood flowing, especially they want to suck out all that blood that's sitting in there. And that is a coagulum is going to, again, be another source for bacteria possibly. The only thing, so I'm going to say I have a pretty low threshold for using it. The negative things about the leech. Had 2 patients. One patient has a little scar from one bite mark. And I just saw it on Skype a couple of weeks ago. And then we may have had one infection possibly, but we probably have used maybe over 200 times, I would say. What do you think, Grace?
Wow.
How many times do we use leeches or more than that?
Yeah, definitely. Ever since I've been in fellowship, you use them a lot.
How many years ago was that?
5.
Okay, so we're talking maybe 300 or 400. So we do that. Sometimes then we'll do hyperbaric immediately. And surgery too, right then we'll start with some nitropace, even though it's a venodilator. We'll start with that. We'll get them on Trental. No ice packs, obviously, on the nose. We might, we got to be careful, use a coapting suture and don't use the Doyle splints in there because of that pressure. What else do we do? I'm thinking if I'm missing anything else with the leech. And usually that works. Again, I've had some noses that have actually became ischemic and then complete to necrosis, especially the columella. And then we'll use a collagenase, some Santal, to take care of that little part right where it breaks down around the incision. And a lot of these patients have healed pretty well.
Awesome. Thank you. Okay, there's a question here. Do you augment your dorsum before or after completing tip surgery?
So if you saw that one video we did, I like now, for the last probably 5 or 6 years, I do the tip. I do everything. I build the tip up. I get my projection exactly the way I want it. And then I get my perichondrium and I suture it over the tip. Then we'll put in the implant. Dean, are you vice versa with your graft? What are you doing first?
I just had to turn my mic on. I'll typically do the dorsum first, set it to the ideal height I want, and then project over that so I get the super tip break I'm looking for.
So good, you got 2 different ways now we do it. Both of us do it differently.
That's great. Okay, so I'm going to have to ask this last question. Any tips or tricks to quickly make diced cartilage?
Dr. Ping, since you've been the queen of doing this and teaching the fellows, I'll let you answer this.
So in general, no. It's just, you just dice it as finely as you can, as fast as you can. I feel like using sharper blades, so don't be stingy with the blades. But otherwise, we also sometimes have a tech help. So once I slice and I'm actually making the grafts, I will give all the extra pieces to the tech who's already dicing, so that by the time I'm finished carving the grafts and I'm actually ready to make the diced cartilage glue graft, like she already has it diced. So it's just doing it as fast as possible.
Wow. So guys, this is absolutely fantastic. It was so good to have the different panelists discussing, and I appreciate you guys being able to help out with that.